Okay, good evening, everybody. Welcome back to the last two sessions of webinar for this year. It's amazing how time has flew this year, and it's been quite a good year compared to last 2 years. So I'm very happy things has gotten back to normal, but everybody is still playing it safe, which is good. And I have with me my colleague from Sunway Medical Center, Dr. Suhail. He was meant to give this talk about maybe a month or two ago, but we postponed it to today because he had some family matters to attend to. So without further ado, Suhail?
Yep. Shall I start sharing?
Yes, you can start sharing.
I think Dr. Suhail,
he left. He's lost.
Yeah, his connection is lost.
Yeah, you wait for a while, yeah? I think it's also because the attendance is less because the application for APC is closed now. So you have to apply. So everybody already got their CPD points. Suhail? Okay, he's back. Suhail, you share again? Okay, great.
Okay, can we see?
Yes.
All right. Hello, everyone. Good evening. I'm here to share with you my experience with the ROSA knee, or what we call as the robotic assisted knee replacement system. We are into this because Sunway Medical Center is one of the few hospitals who's pioneered into venturing into doing this. Now, I started off doing robotic assisted knee replacement some 10 years ago. Unfortunately, we couldn't buy the machine.
Already. You had the robotic 10 years ago.
Yeah, we first did the first case 10 years ago, but the software only allowed us to do a partial knee replacement.
I see.
Hence, to spend over 5 to 6 million ringgit to buy a robotic wasn't a good idea. So we decided to abandon the project. And in 2019, we started back going into this because now the software allows us not only to do a partial knee, a total knee, and as well as a total hip replacement. So hence the enthusiasm worldwide to use the robotic assisted knee replacement. Now, if you look at the what you call the experience worldwide, especially if you draw experience towards Australian people, we have, if you do look at 100% of total knee replacements that we do, 84% comes as total, and maybe another 7% is actually a partial knee, and maybe another 8% volume is revision total knee. So in my practice is somewhere around 10% where we do partial knee replacement, especially if patients turn up early to see us and if they are referred early. So so if patients who have got severe knee pain and they have got a unique compartment disease, either medial compartment, lateral compartment, or patellofemoral compartment, they can actually have a partial knee replacement and go back to good life, rather than waiting for them to end up having a total knee replacement 10 years down the line, having consumed a lot of pain relief medications. And at times we have to tell them, sorry, their risk is too high because they've got bad kidneys, and they've also cardiovascular problems eventually. So if you look at the experience in total knee replacement, unfortunately, the ratio is slightly higher with the females as compared to men. And there are many reasons for this. One of them is because people believe that ladies have what you call, because of their hormone, their ligaments are a bit more lax, and as a result, they've got higher tendency of ligament injuries, and also due to the laxity of the ligaments, they are predisposed to osteoarthritis. One. Second thing is post-menopause, a certain amount of patients tend to put on a lot of weight and increase in body weight definitely increases the load in the knee, among other factors. Now, this is just some of the factors. Now, so what is the big buzz about knee replacements with robotics, with navigation? I'm sure some of you would have heard. And then with image dependent instrumentation. Now, basically, when we do a knee replacement, we want this knee replacement to be a lifetime surgery. That means one knee replacement for the entire life. Hence, we want to have the implants in the best possible position so that this will transform to the long lasting of the implant. So if your implants are placed in the best positions possible, then they obviously will last longer. So if you don't last long, what happens? So they don't last long. You saw in the earlier slide where you got 8.4% a revision rate. So revision basically means they have to come in and we have to take all those implants off and put in a new set of implants. So that would mean a bigger surgery, a more costlier surgery, and we have to deal with lesser bone stock, because when we remove all those implants and the cement, we lose some amount of bone as well. So the idea is, if you put in a knee replacement in the best possible position, then it will last longer. So that's why there's this enthusiasm in going towards computer navigated and robotic surgery. I mean, me and my team ventured into computer navigated surgery in 2006, way back whilst I was in UKM itself. So over the years, we have now upgraded from a computer navigated to a robotic assisted knee replacement. And you can see from this slide, at least, the revision rates are lesser when you are using better technology. So if you look at this slide, it basically shows that when with computer navigated and non-navigated, the risk for revision is higher in the non-navigated patients. This basically shows the cumulative results of patients with robotic versus non-robotic. So if you can see that with the non-robotic, which is the greener one, the cumulative percentage of revision becomes lesser as the years go by. And if you draw this line graph down 10, 15, 20, 30 years, eventually you will find there's a big discrepancy between the robotic assisted and the non-robotic assisted. So what is this system called? The ROSA system. ROSA basically means robotic assisted knee replacement. By no way the robot takes over the function of the surgeon. You still need the surgeon. It's surgeon-centered. It's accurate and it's reproducible and it's very, very efficient. So, so basically what happens is, if you can look at this picture on your right, that's me operating. That's the knee of the patient. I'm holding the foot on my right hand, and the robot is on my left. So basically what happens is I still need to do the what you call I still need to do the exposure. I need to still show the bone, mark the points, and then I bring in the robot, and the robot is used to assist me to do the bone cuts. So this is how the robot functions. So the robot arm is brought to the bone, and then it's placed on the bone. This is a saw bone, and you can see how precise the robot is. Whichever direction you move, it will cut in the best possible position. Now, this cutting amount of bone, the angles, all this is done pre-operatively. So basically, it's all calibrated. Patients' x-rays are taken, and from the x-rays, these figures are all done. So basically, what we are doing is we are using x-rays. So we send the patient off during our pre-operative consultation to the x-ray department. 2 sets of x-rays are done. A long film, the entire hip, knee, and the ankle is captured in an AP and also a lateral position. And this is then fed into the Atlas technology. And this Atlas technology will recalibrate the entire bone morphology and tell us, okay, this is the angle of this patient. This is how much you need to cut. And what are the angles that you need to put this implant in so that it functions the best position. So basically, it helps us to gives us better alignment. It restores the rotation of the femur. It allows us to balance the tissues and also gives us good range of motion. So traditionally, what we used to do is when we didn't have this robot, we have been doing knee replacements for the past 20, 30 years, more than 30 years, in fact. I've at least been indulging in knee replacements for the past 22 years. So, prior to this technology, what we used to do is we used to insert rods into the femur and into the tibia, and there are jigs which are fitted onto this. And based on our calculation, a pre-operative calculation, we cut the bones so that we realign the bone. You must understand that when somebody comes in with either a varus or valgus deformity, when they end up doing a knee replacement, you get them back to straight alignment. So that's what we are trying to do. So when we used to do it using the conventional method, there are always occasionally, not always, occasionally there are outliers where the implants are positioned in not the best position that we want it to be, because there is always human error, there's always jig errors, there's always bone morphology, which is some patients' bones are bowed more than the other. So hence that eventually transforms to the longevity of the implant. So if I give you this example of this picture, this is how the screen looks like after we have fed all the information into the computer and we have marked all the bone marks. So this tells us this patient has got a varus deformity of 10.5 degrees. And after the calibration, I can actually bring it down to 0 degree. And imagine how precise we can actually get this to. So that's how this computer helps. So, and then before I actually make the cuts, all this planning, so it will tell me how much bone I'm going to take away from the medial femoral condyle, 7 millimeter, 10 millimeters, and how the implant is going to look like once I've made the cuts. In the good old days, once I've cut, once I've put my trials on and I've cemented, the only time I can see this position, apart from seeing with the naked eye, is the post-op x-rays. Today, I can decide all that before I even make my final cuts. And this is how it's going to look like at the end of the day. So I have a picture in front of me showing me how this patient's knee implant is going to look like in the x-rays after the surgery, even before the surgery is completed. So you can imagine that allows me the room to make changes, to change the angles, to make more better precision, to get the ligaments more balanced and to put it in the best position that the patient needs it. So this is how the x-ray is done. These two gadgets are put on and the patient is sent to the x-ray department, and in the x-ray department, they do these x-rays, and then the calibrations are done. And then from those calibrations, we'll know what the angles are for this patient. And then this information is fed into the computer, and there's a technician who looks at all this and calibrates everything. And then the information is sent to me before surgery so that I can decide that this is the workflow that I want to have in this patient compared to any other patient. So you can see how it's morphology. And this technology is so good that this 2D X-rays is as accurate as doing an MRI for the patient's knee. Yeah, so this is how the morphology is done. So if you can see, even in terms of the operating theater efficiency, the top picture is what my operating table looks like now as compared to previously. You can imagine all the jigs and the things that I need to use before as compared to what I'm using now. So that reduces the cost, that reduces the amount of autoclave, that reduces the confusion from my operating theater staff. So yeah, so this is how in the operating theater the view looks like. So the camera is on the opposite side of where I'm operating, and then there's the other view is the robot view. The robot is on the side where I'm actually doing the surgery, and this is how it looks like in our OR. I'm operating on the patient's right knee. The left on my left is the robot, and the camera is on the opposite side. And you can see how simplified the tray is as compared to the one which we saw earlier on.
But you actually have to stand there and operate also. You can't be in a, you can't sit down and just manipulate the the AI from
Okay. I get what you're asking, Betty.
Yeah.
That's what happens in the Da Vinci and what the general surgeons do and the
yes.
urology do. So they are operating from another room, and
Uh-huh.
then they move the gadgets, the arms of the robot
Yes.
from a different room. So for orthopedic surgeons, I have to be there. So
Oh, I
that makes
see.
that makes my presence important. So
Oh, okay.
so that means that I because for us the incision is not laparoscopic. So because you can imagine the size of the implant, so you really need to open that big, about 10 centimeters or so, in order to be able to put the implants inside. So that's why this is not a robot taking over the surgery, but the robot is an assistant. So the robot assists me to cut the bones in order to place the implants in the best position possible.
I see.
So
Okay.
so I have to be there. I can't be in another room. I can't be having my coffee in another room.
Yes, that's right.
So there are many studies available throughout the world showing how accurate this ROSA is. The standard deviation that we have is about 1.1 millimeter. Can you imagine the precision? 1.1 millimeter and up to standard deviation of 1 degree. I mean, how accurate more would you want to get? So this is an example how the bone cut is being made. And you can see if you have cut the bone, you're not happy and we want to do a recut. And if I think that I want to have a 2 millimeter cut, you can see the chamfer of the bone on this on the top right hand corner. That's how 2 millimeters actually look like. So that's how precise the cuts are. So these are some of the information that I have to mark on the computer on the patient's bone in order for the computer to know the landmarks of the patient's bone. So this is an example. This is how the surgery looks like. That's an incision. We have got two trackers, one on the tibia and one on the femur. So these trackers pass the information through the camera to the computer. And this is what I'm doing. I'm trying to bend the knee back and forth so I can know how many degrees of varus and valgus there is in this knee and how many degrees of flexion I can get. This is a trial implant. So you see, all this can be done before the implant is actually cemented inside and the wound is closed. So you don't
Hello?
with full confidence that what you have put inside is what you have seen in this
Oh,
diagram and it's what you have planned. Yeah. So these are some of the studies to show us, between conventional and also the robotic, and you can see in all parameters, the femur, varus valgus, flexion extension, tibia, varus valgus, tibia anterior, posterior. In all circumstances, the robotic has got much more precision as compared to our conventional methods. Yeah, and so basically, if you're doing a knee replacement, you can get up to 100% of your cases within 3 degrees of what your targeted hip, knee, and ankle axis is. So yeah, sorry, you wanted to ask something, Betty?
Yeah, I want to ask you, this ROSA system is not the same as the Da Vinci one.
No, it's not the same. This system, the ROSA, there's another system from Stryker called the Mako system. These are only for orthopedic practice. It cannot be used for any other practice.
Okay, I remember you giving a talk was it early this year or last year? On, and at that point of time, you touched a little on
robotics.
Robotic, but was it the Da Vinci system at that time?
No. It's still the ROSA. Still ROSA.
Okay.
Yeah. So we have both. We are one of the only hospital in the country which has both systems, ROSA and Mako. These are the most famous systems throughout the world and who have got the best results as far as the current time is concerned.
Da Vinci system cannot do orthopedic.
Sorry.
The Da Vinci system
cannot.
I
cannot. So sorry, excuse me for this picture. I mean, it was probably a high resolution picture. It's just to show you a simple example of somebody who had this femur fracture with a plate and screws which are broken. some 20 years ago. And this gentleman was about 85 years old and who had got so much difficulty walking. Can you imagine how he's walking in this position? And after the splay and screws were removed and the implants were put in, this is how the right-hand side, the knee looks like. And he was so happy that he wanted the other knee to be done. So you can imagine the difference from between the left picture and the right picture. I'm going to go in and show you other pictures. So this was his other knee, the right knee, the left knee, also varus, and post-surgery, how straight, how good the alignment is. These are some of the other x-rays. Another patient who has got a varus deformity, you can see the medial compartment completely gone. Post-surgery, see the alignment that we have gotten, and how happy can someone be, for the past 15, 20 years walking around with that kind of a knee. And this is another example of a very bad knee, bilateral knee with complete obliteration of joint space. The left one has got even a bit of a subluxation, and you can imagine both the femoral condyles have eaten into the tibia. And post knee replacement, you can see how straight and how good the alignment is. Okay, this is another example of another patient who had 15 degrees of valgus deformity on one side, and she had another knee which has got also I think about 15 to 20 degrees. So now, because of anatomical reasons, when somebody has got significant valgus deformity, if you overcorrect them to 0 degrees, you will track on their peroneal nerve and they will have a foot drop. So because of that reason, we erred towards a bit more safe, and we just decided to correct it up to about 3 degrees. And this is the pre-operative x-ray of this lady, bilateral valgus knee. And that's the post-operative picture.
Wow.
You can imagine, I mean, she's not only gotten height, she's gotten the knee straight. Her neighbors are wondering, this lady who has been limping and walking around with almost like that duck gait kind of movement, and now she's walking upright straight. I mean, how could you not change someone's life if you give them this kind of a surgery? So I think I'm towards the end of my lecture. I just want to share with you one video. If you can give me a little bit of time, let me just show you this video.
And the best thing is, because of the pain that this osteoarthritis induce, a lot of patients are actually very acceptable to surgery. Yeah.
Yeah.
The pain is tremendous.
You're right. Pain can be very, very uncomfortable. I mean, some of them have been suffering with pain for the past 15, 20 years, knocking on every pharmacy and every Sinsen and everybody else to get pain relief medications. Half of them have already gotten their kidneys barbecued because of the pain relief medications. When I started doing knee replacement 20 years ago, we used to tell patients who are young, go off, don't come back, go and do your knee replacement, come back when you're much, much older. And by the time, eventually, when I saw them when they were much older, the kidneys were bad, they had already gotten other comorbids, and sometimes we have to tell them, no, we can't do surgery. But today we have the technology to do a knee replacement for a patient. We have technology to do a revision knee replacement, a re-revision knee replacement. And with this kind of current technology and the implants that we are using now, we are pushing the limits of survival rate from up to 25, 30 years. So, I mean, how good how much more do you want? So just watch this simple video. It's a video of a patient of mine who had a very bad injury when he was much younger. This gentleman is about close to about 50, 52, 53 years old. He had osteoarthritis of his knee because he had a malunited femur fracture. You can see how he's walking, how slow. And he was 2 centimeters short on his left lower limb. And if he had gone for a conventional method, he had multiple surgeries. So he's from 22 degrees of valgus, whereas we did a pre-op planning of 0 degrees. So of course, after the surgery, you've got less pain, you can recover faster, less bleeding, better precision. So these are his x-rays. Bad femur fracture, 22 degrees of varus deformity. Post-surgery, of course, we don't correct the deformity on the femur, but his knees are straight. And 2 weeks post-surgery, you can see the speed of him walking. It's just 2 weeks.
What
No
is the
walking
problem
aid.
with doing surgery too early for young patients?
Yeah. Okay.
Can it last? Can it not last?
Yep. I'll answer that. Okay. Okay. Can you see me, Betty?
Yeah, I can see you.
Okay. All right. So the question is, what is the problem in doing a knee replacement for somebody who is young?
Yes.
So if you're looking at someone who is young, let's assume someone who is about 45 years or 50 years old. This person has got a life ahead of him. He's still working, or he or she is still working, still has got a lot of mobility. And hence the usage of the knee replacement implant would be high. So these implants work in the cycle of the million cycles that they get used. So if I use that 5 million or 7 million cycles within 10 years, obviously the polyethylene inside the implant will wear off. So once it wears off, then eventually the implants, because of the inflammatory response, the implants become loose and you have to go in to remove them. So now what we have moved is we have gotten into using better metals. We have gotten into using better polyethylenes, cross-linked polyethylenes now, even with antioxidized vitamin E polyethylenes. So this is all pushed the duration or the lifetime or the expectancy of these implants much longer. And now we have got these robots to place the implants even in a better position. So we've got better implants, we've got better poly, we've got better technology, and we are getting better at it because we have been operating for the past 20 over years. So obviously we are pushing the benchmark higher and higher, and patients are doing better and better. So as a result of that, we are able to now lower the age. Instead of waiting for somebody who is 60 years old, we can lower the age to about 50. But again, it's only if and only if it is necessary. We don't usually, these knee replacement surgeries are not something that is offered as a first line of treatment. It has to be that the patient has exhausted all possible conservative management before we are looking at a knee replacement. But having said that, sometimes some patients are just so much in pain, and they need to take so much of painkillers, and you ask them to wait from 50 to 60, they have lost their entire age of 50, their ability to go out, travel, do work. There's so much in life they have to give up and wait until 60 and then go ahead and do the surgery and then say, oh, I'm 16 and I can't travel, I can't do this, I can't do that. So we as doctors have to try to give our patients the best. So this is what we are trying to do.
Okay. Because I foresee, right, that this is going to be a normal thing for a lot of patients these days, because I'm seeing patients in the 20s and 30s who are like 110, 120 kg, and they're mainly more so women than men. I do not know why. So this will definitely cause premature osteoarthritic changes, I'm sure. And then they can't exercise because therefore they can't lose weight. They can't lose weight, therefore. So I see that you're going to have a lot of work soon.
Yeah, I mean, the two parts to this, Betty. Number one, I mean, sometimes when we see very young patients who are obese and who have got a lot of knee issues, we usually try very hard to send them off to see the dietitian to start reducing weight. And even sometimes nowadays we even send them to see the bariatric surgeons to get them done before they lose further their cartilage in their bones, and their knees become bad. But having said that, you rightly pointed, when somebody is very big and they are not able to do exercise because the knees are so painful. So pain, you can't do exercise, you put on more weight, and your knee just goes down the vicious cycle. So sometimes what we do is, after we have given the patients anywhere between 3 to 4 months or 6 months to see if they have tried very hard, and if they are not open to the idea of bariatric surgery, what we do is we quickly get the knees done, and then we start what you call we start doing the surgery and then getting them to do exercises. So that is something that we do. And the second point that I want to make is, apart from the fact that we are beginning to see a lot of obese people in the young age, we are also an aging population country.
True.
So I have my patients who are 85 years old who walk into my clinic and say, look, I don't want to live with this joint. I want to have a better life, and I want to have my knee replaced. I think my oldest knee replacement patient is about 89 years old. Yeah, so people want to move, people want to have a better life. So we should try and give them the best if possible.
Okay, is the surgery faster, and are there less infected?
Okay. Now, I'll answer your second part first. One of the biggest nemesis for knee replacement is actually infections. At the moment, with whatever things that we are doing in terms of ultra high flow OT, and the antibiotics, and our what you call care that we give our patients, we are able to, most centers, if not all, most centers should, if it's a good dedicated joint replacement center, should have an infection rate of less than 1%. Worldwide, that's an acceptable, that's what's accepted, number one. Number two, what was the other question? Sorry, you
Is
asked
the
something.
surgery shorter for
Shorter, okay, all right, shorter. Okay, duration-wise, I think more or less very much similar. I mean, it takes a surgeon who is regularly doing robotic surgery about the same time as he does conventional, maybe another 5-10 minutes extra at the most, but not very much longer. I know if you look at the general surgery or the urology group, when they do knee replacement surgeries, when they do robotic surgeries, the time taken is actually way much more longer as compared to us. So we basically more or less similar timing.
I want to ask, okay, now our center, Sunway Medical Center, has, I think, one of the most sophisticated and the newest generation of robotic surgery equipment. How do we then share it or impart the knowledge that we gain with the junior doctors? Is it about time that we run some workshop?
Okay, I'll tell you what I do, what we do.
Mhm.
In orthopedic practice, at least in this year's Malaysian Orthopedic Association general meeting, we had a cadaveric workshop in Shangri-La itself.
Oh my God!
Yes, in Shangri-La. We had a
Interesting.
cadaveric demonstration. We had a robotic sawbone workshop. So we are beginning to train our doctors countrywide to use these robotics. But mind you, Betty, this technology isn't licensed to be used by everyone.
Yeah, that's right.
All joint replacement surgeons must undergo conventional training first, number one, before they can embark on a robotic. And you must be licensed to use a robotic. You must be certified, you must be credentialed in order to do a robotic surgery. And at the moment, I think there are around 5 robots or at least 4 robots out in the country moving around from one place to the other. I think some of the other private hospitals are already beginning, or if not, have already begun to get their own robots. But then again, there's a lot of training that needs to be addressed before everyone is allowed to use the robot. But it is something to look forward to.
Okay, any more questions? Today is quite a short talk, but we still give out a QR. We have shared the QR code for one CPD point. Okay. Somebody asked, Dr. Suresh asked, is ROSA method what?
Good.
Can-
Yeah. Okay. Can I address this, Betty? No problem. Okay. It's a very good question. I mean, the question is, does the ROSA method reduce post-op pain versus conventional method? I'll give you an example. My knee replacement surgeries are done on every Wednesdays. Now, patients come in on a Tuesday. They have the surgery done on a Wednesday. Thursday, God willingly, they are able to start walking. And by the conventional method, most of them go back home the following week, Tuesday or Wednesday. So they stay in the hospital for almost a week, 7 to 8 days before. With the robotic method, my patients are already demanding to go back home on a Saturday. That means post-op day 3, they are very comfortable to want to go back home because they don't need any more injectable parenteral pain relief medication. So then the question comes, I mean, why? If you're still cutting bone, but the amount of soft tissue release that we do when we are doing the conventional method is way more. So there's less soft tissue dissection. There's less edema. There's definitely less pain compared to conventional method.
Okay, coming back to this duration of admission and duration of stay, some hospital claim that you can have a day care for total knee replacement. What are your thoughts on that?
Okay, I mean, I think it's actually something which is good if you can do it, and it must actually translate to betterment for the patient. Now, I have a problem doing total knee replacement as a daycare. Reason being, total knee replacement is a big surgery. It has got its potential risks. There are risks of infection. There are risks of deep vein thrombosis. There are risks of fat embolism and the whole works. And the push for wanting to do a daycare surgery is actually mooted back in the United States, where they were very concerned about care expenditure, and the insurance companies were giving hospitals a refund on if their patients can actually go back home early. Here we don't have that that issue. And number two, most of our patients, I mean, I'll give you an example. If my mom had a knee replacement today, and if she wanted to go back home today, I'm not prepared to look after her at home today because I've got to go back to work tomorrow morning. And even if I can look after her for the first 3 days, what's going to happen to the 4th, 5th, 6th day? So the first few days is essential for me, for the patient to be in a hospital care where somebody can look into them. There's physiotherapy, there's nursing care. Twice a day they get physio. So if they go back home, then there must be a setup where a nurse has to go and visit them twice a day. There must be a physiotherapist going to visit them twice a day. And worse still, none of the insurance companies in Malaysia will all of that, reimburse them for that. So we don't see, so you have increased the potential position of a risk of patient sending the patient back home without any significant added advantage, except for the fact that you've given them a home environment. So I think that's a bit difficult for me to accept. I think at least 24, 48 hours, the patient should be in the hospital for a thorough observation. And you must realize also, most of our patients in their 60s have got so many comorbids, so with all that comorbids, a bit difficult to go back home. Okay, can I address some of the other questions?
Yeah, sure.
Somebody, Dr. Kavish asked cadaveric studies. I think you're asking if there are cadaveric studies. There are ample cadaveric studies before. We are already past that level. Now we are already on all the studies that are coming out now on real patients, simply because we have already gotten past that phase. What is the cost for a single knee replacement? Insurance cover? Do you advise to do both replacement at one go or one at a time? Okay, the answer is, what's the cost? I think at the moment for a robotic knee replacement surgery, it works up to slightly less than 40,000 Malaysian ringgit. Number one. Number two, is it covered by insurance? Yes, insurance are covering because hospitals are not charging extra for the robotic services, only for the consumables, which you saw earlier, the blue trackers and all that. Do you advise to do both knee replacements at one go or one at a time? Now, knee replacements can be done both at one go. All the surgeons would have their own criteria. My criteria is very straightforward. If you are beyond 70 years old, I don't think you're fit. You should go and have both knees done together. All studies point that doing bilateral knee replacements have got slightly higher risk of fat embolism, slightly higher risk of deep vein thrombosis, and also infection. So if you are young and you don't have too many comorbids and your comorbids are very stable, ideally you can have both done. Are there any circumstances that I would do both at one go? Yes. If I have a patient who has got severe bilateral varus or valgus deformity, example, more than 15 degrees of varus. If I straighten one knee, he can't still walk on the other knee because the other knee is half short still. So in those kind of circumstances, provided the patient is fit, we go ahead and do both. I would do both. Otherwise, I would do one at a time. And the other question is approximately how long does this ROSA knee surgery takes place? It takes about 45 minutes to an hour and 15 minutes. So around that.
So short.
Yeah, so about 45 minutes to an hour and a half at the most. So we are looking at that. So it's not 7 hours or 6 hours like some of the other robotic surgeries that are going on. So in most trained surgeons' hands, I think in at least in Malaysia now, I think most of my colleagues who are in robotic surgery will tell you it takes them about that time. Would you be able to point towards material pertaining to clinical outcome? What?
I think you did share some, right?
Yeah, so I mean, so material pertaining to clinical outcome. What we have is there are a few things. One is the conventional material that we used to use is cobalt chromium. We have moved forward material. So moving forward, we have oxenium. That means ceramic coated implants, which has got less friction, less wear. That is one. Number two, the polyethylene that we used to use used to be gamma radiated polyethylenes. Now is ethylene oxide, and we also have got polyethylenes which are highly cross-linked. Hence, the wear rate is very, very, very low. And now we've even gone on to vitamin E anti-oxidized polyethylene. So that has also changed. How much are the charges for robotic unilateral and bilateral knee replacement? So for unilateral, I said slightly less than 40,000. So if bilateral, you are looking at almost double, except for the fact that the only thing changes is your hospital stay. Instead of coming in twice for hospital, the room stay, now you're staying once. In terms of everything else is double the implant, double the operating time. Yeah, so it's probably the antibiotics and the medication that you're using once now compared to using twice as versus the hospital stay. So those are the few differences. But I must emphasize on safety. I think if you or your family members are deciding on a knee replacement, and yes, I mean, if you look at it, if I go to the hospital, if I get it done once, fine. Why do I need to go twice? But you must understand that there are risks involved in doing bilaterals at one go. I think if you speak to all joint replacement surgeons who have embarked on bilateral, everyone has a story to tell. So so be careful if you're really embarking, and you must have real good reasons why you're doing bilateral at one go, not because you don't have the time. And my daughter is working and my son is having a busy practice and he can't come and visit me, so we're going to have bilateral knee replacement done. I think that's not the right thing to do.
Don't rush it now.
Yep, you shouldn't rush. It's a painful surgery. It takes a lot from the patient. There's a lot of physio that's required. Patients have to undergo quite a bit, but the outcome is good. And so
yeah,
that's why that. Sorry.
I've seen like really good outcome.
Yeah. So I mean, if you look at the literature will tell you one of the most gratifying surgery that man has ever invented is not a cardiac bypass, but it's a joint replacement surgery. It changes your life. Patients will tell you they've gotten back their life 25 years back. Their mobility is better, their movement is better. They can do a lot of things that they couldn't do before.
Okay,
Yeah.
there's some
So
more. Yeah, go on.
hip replacement, are they still conventional and non-robotic? No. Some of my colleagues have begun doing hip replacements with robotic. It's still very, very new. The reason why it is not taken up as much as a knee replacement is robotic hip replacement only sets the cup, the acetabular cup. It doesn't do anything else to the femoral implant. So it's not the whole thing. So it's only one part of it. So some of us find it not so what you call interesting to embark on that just yet. But a partial knee, yes. A total knee, yes, definitely.
How about trauma cases?
Trauma cases, so I give you an example. If somebody has got a distal femur fracture or tibial plateau or proximal tibia fracture, they cannot have a knee replacement until the fracture is fixed and the fracture is united.
No, what I'm trying to say, can you use this ROSA system for trauma?
No. This is only for joint replacement.
Oh, I see.
Yeah, so the technology is only for joint replacement. You can't use it for trauma. Now, there are robots which are coming out for placement of spine pedicle screws in appropriate places. That's something new that's coming up. I think in the near future, if not in the next 2-3 years, you'll probably have that available. Yeah. How much are conventional hip replacements? Conventional hip replacements cost around 30,000 ringgit, 28 to 30,000 ringgit. But there are some minor changes which change the cost of the implant. Example, if somebody uses what we call as the newest thing implant that we use now is a dual mobility, which has got hardly any risk of dislocation, and gives the patient significant range of motion. The patient can kneel, can squat down, and the rest of the stuff. That pushes up the implant price a bit. The metal head that we use, if you use a completely ceramic head, that pushes the price a little bit higher. But generally, I think even if you use a dual mobility, even with a ceramic, should cost the patient roughly about 40,000, maybe around that.
The age for patients for knee replacement and hip replacement are quite different, right? The demographic.
Yep. So in our Asian population, you will find majority of the patients need a knee replacement compared to hip replacement. So places like Australia, UK, the Western population, you will see the reverse. You'd see in our population 80% knee replacement, 20% hip replacement. It's completely the opposite in the Western population. That's probably answered by the fact that we do use our knees more for kneeling, for praying, for squatting down, and the rest. And the Western population, people probably don't use it that much.
I see.
Yeah, so that's one. But how at what age do we? And of course, the other thing is our populations of patients who need a hip replacement are very few fall in the category of osteoarthritis until they become very old. So one group is osteoarthritis, second group is fracture neck of femurs in the elderly.
Yes.
Of course, the other group that we find is avascular necrosis with all this traditional medication and patients who are on long-term steroids and all that, who have got, or alcoholics and all that, who need a hip replacement. So that age drops a little bit. SLE patients and all them. So in those age, definitely is much more younger, much younger.
For osteoarthritis, right? Is there a genetic predisposition for osteoarthritis of the knee?
I mean, there is no study to prove that osteoarthritis is genetically but if you see in some families hereditary, they'll tell you, their mom has, their grandmother has, and somebody else in the family has, but I mean, there's no genetic predisposition. I mean, as of scientific predisposition, we don't have any.
Well, the Q&A session took up a lot of time, so we are done
That means a
quite-
lot of people are interested. That's good.
yes, it's good. I'm
Yeah.
also very interested in this ROSA system.
I hope you don't need one, Betty.
Oh, I won't. Okay, touch wood, touch wood. No, lah. None of my family have OA of the knee.
That's good. That's good.
Yeah,
I mean,
it's like
yeah, that's good.
yeah, but we have
yeah.
other problems, which is like cancer on my father's side and coronary artery disease on my mother's side. But
Mm.
well, otherwise, we don't have any problem with OA. Okay, so Dr. Kumar said, I'm very impressed. Okay, the word
Welcome.
impressed. Oh, by the
Welcome.
yeah, I also very impressed. Oh, do you work?
Okay.
You have to work very closely with the radiologist?
Not, I mean, the X-rays that the patient does, it's calibrated into a software, and the software is sent off to Singapore for the engineers to look at it and tell us, you know, what the plannings are supposed to be and all that. So not directly with our radiologists, not with our
I
radiologists.
see.
I mean,
So
there is
this will take how long?
okay, so the robotic surgery has got we have got two options. One option is an imaged surgery. The other one is imageless. So if somebody walks into my clinic and tells me, say, look, my knees are bad, I need to have a surgery in the next 24 to 48 hours, especially our patients who fly in from overseas, like from Middle East and from Indonesia and all that. So they come in and they want to have surgery done quickly. So that we do what we call as imageless. That means we do the simple X-rays and then we mark the bones as we go on in the surgery with the robot. Now, if we have the time, ideally, the ideal situation would be to do an imaged one. And imaged one, there is a turnover time about 3 days to get the image processed and get the feedback. Yeah, so it takes about 3 days or so, for us to get the feedback.
Okay, a very important question that I nearly missed from Facebook. Shui Chiu said, Doctor, is there any way to prevent knee osteoarthritis?
Okay, the simple answer to this question is, what I tell patients is, if you don't get osteoarthritis when you're 25 or 30, it's going to come at 50. If it doesn't come at 50, it's going to come at 60. If it doesn't come at 60, if you live long enough to 85, you'll probably get some amount of osteoarthritis. So basically, osteoarthritis is a degenerative process. So as long as we live, we move our joints. And you can't imagine moving your joints without having friction, without having any wear and tear. It's unlikely to happen. But what can you do to reduce it? So in order to reduce it, you must have good stable joint. That means you must not have, if you have a ligament injury, you must address the ligament injury. If you're going out to do sports, understand your body and do the right sports. Get good shoe wear, good footwear. If you're going to run or jog, do proper training, learn how to run properly, rather than just putting on a pair of shoes and running tomorrow morning 25 kilometers. I mean, it doesn't make sense. So if you take those steps, ideally, you could reduce the risk of getting osteoarthritis. But I don't have the magic thing to tell you that if you do A, B, C, D, you can forget about osteoarthritis of the knee.
Which is very true, because I do a lot of hiking, and this year I've climbed Mount Kinabalu and Mount Rinjani, and a lot of people in my team, after the climb down, it's not a climb up, but it's a climb down. My friend, after now 5 weeks, still can't train for the next climb because his knee. So the main problem with most people after the hike is the knee problem. Will stem cell injection help? Okay,
there's another question. Let me just answer this question. Dr. Ng is asking, thank you for your talk. Knee replacement, would it be helpful for dysplastic hip with leg length discrepancy in the same leg? Not keen for a total hip replacement, high risk of dislocation and knee grade 4 OA. Okay, so let me understand this question. So basically what he's asking is, he's got a patient who has got a dysplastic hip. And as a result of the dysplastic hip, that means we have got a high riding hip and the limb is shorter. And as a result of that shortening, that patient has also got an ipsilateral knee osteoarthritis. I mean, this is quite common, Dr. Ng. Can we do a knee replacement for this patient? Yes, we can. But we must understand that there's going to be a lot of force on the knee to compensate on the hip. One, because it's good, the patient's already got a limb length discrepancy. So once the surgery is done, the patient will still need her heel raise to compensate the shortening on that side. I would suggest look up a proper, a good joint replacement surgeon, and look into the idea of doing a hip replacement for a dysplastic hip. Most joint replacement surgeons who are well trained have the ability to do a proper hip replacement for a dysplastic hip. Understandably, the risk of dislocation is high, but nevertheless, it's something that actually can be looked into. So going back to your question, can it be done? Yes, it can. Is it true many young knees are initially damaged in the gym workout? So, well, there are two groups of people who go to the gym. One who have a proper training, and then have a trainer, and then after some time they embark on their solo self of in the gym. So if you train yourself properly, you know what to do in the right manner. Ideally, yes, you can get injuries, but less likely to get injuries frequently. Now, the problem is a lot of people go to the gym and become a gym member. They don't have much clue, but they look at the what you call YouTube, how to do the exercises, and then they do the exercises in the gym and then get injured. And then when they get a lot of injuries, they don't take time off and they go back again to the gym, and then they keep doing the exercises. So a simple example is when you do the leg presses, at the end, when the leg press is pushed to the maximum, the knee shouldn't be 0 degrees of extension. But the problem is everybody wants to lock the knee in that position. Once you lock the knee in that kind of position, you damage your ligaments, you tear your ACL, you tear your collateral ligaments, and then you run into trouble. Question, glucosamine, any help? A lot of studies, some say yes, some say no. Simple answer, give your patient for 6 weeks. If the patient doesn't have any improvement, forget about the idea of giving them the glucosamine. But if it does help them within the first 6 weeks, then obviously you can allow them to continue. You asked something about stem cells, Betty, just now.
Because I have a lot of friends going for stem cells under certain doses.
Yes. Your question is?
So does it help?
Well, how can I say this? You see, I tell people this. I mean, stem cell has been around for a while, and people have tried using stem cell for knee osteoarthritis for the past, 10, 12, 15 years, maybe. Now, the thing is, if stem cell was so good in everybody's knee, then obviously I would have changed my training from being a joint replacement surgeon. Rather than embarking on robotic surgery, I should have gone into stem cell.
Yes.
Okay. So, and no, I tell you, I kid you not, 20 years ago, when I first started doing joint replacement surgery, I was at this crossroad and thinking, if stem cell is going to work, I'm not going to have any more work. And I was in the dilemma of trying to think, should I just go and do something else, and rather than look into joint replacements as my subspecialty, because obviously people are going to use stem cells so much that nobody's going to have knee replacement, and that hasn't happened 22 years down the line, and I doubt it's going to happen for a while, because the stem cells probably help people at early stage, but I don't think they're going to help everybody, and it's very, very costly, and the insurance doesn't cover. Most corporate bodies don't cover. So yeah.
Yeah, the stem cell injection is maybe about 1/2 of the total knee replacement.
Depends on if you need to go for double.
Oh, I see.
Yeah. I think the cost is anywhere between 20 to 40,000 ringgit or so. Yeah.
Wow.
Yeah.
Okay.
Yeah. Any more questions? No more questions? Okay.
So,
all right. Thank you.
Thank you very much.
Thank you for being a very good set of audience. Betty, thank you very much for the opportunity. I hope all of you have learned something, and it will be helpful for your patients. feel free to touch bases with me. I'm at Sunway Medical Center. I don't practice in any other hospital. You can call the operator and you can speak to them to get to speak to me. I'll be happy to answer your questions. Yeah, we are here to help people. And if you think that you don't want to have it done in Sunway Medical Center, and if you want me to point to you another place for you to have it done, by all means. I mean, like I said, we are here to help everyone.
Yeah.
And good evening and thank you very much.
Thanks, Suhail. I see you one of these days at
Okay.
work.
Bye-bye. Take
Bye.
care.
Yeah.
Bye-bye.
Thank you.
Cheers.
Bye-bye. Okay, bye everybody. Okay, before you leave, next week, we don't have a session because next week I have a party to go to. So it's
Wow.
it's been postponed to next 2 weeks. I will inform you guys, yeah. Please join our Telegram group chat so that you will know the latest update. See you. Bye, guys.
Bye, Dr. Betty. Have a
Okay.
good night. Have a good rest.
Yes. Thank you. Thank you, everybody. The next 2 weeks, we're going to have it's like a case study in cardiology with hopefully with interaction with the people and see whether we can get it going. Bye.